Functional visual loss. Functional visual loss, FVL, is a decrease in visual acuity and/or visual field not caused by any organic lesion. It is therefore also called non-organic visual loss, NOVL. This entity is considered within the spectrum of conversion disorder, malingering, somatic symptom disorder, and factitious disorder. We prefer the term NOVL because NOVL does impact function and the eye exam is not able to differentiate the presence or absence of secondary gain. NOVL is a decrease in visual acuity and/or visual field not caused by any organic lesion. NOVL cannot be explained by organic pathology after a complete neuro-ophthalmic examination. The decrease in visual acuity may involve one or both eyes and may vary from mild blurriness to complete blindness. The visual field defects may affect one or both eyes. They may include constricted or tunnel visual fields, and hemianopias, among other complaints or visual findings. NOVL is often but not always associated with concurrent diagnoses of depression and anxiety. The diagnosis of NOVL is frequently confirmed at the neuro-ophthalmologist's office after referral from a general ophthalmologist. NOVL runs the spectrum from the malingerer, to feign for secondary gain, to subconscious visual loss caused by underlying psychological disorders in the patient. Thompson provided an excellent description of this spectrum of functional patients. At one end is the deliberate malingerer, who is faking visual loss to gain disability, benefits, or attention, among other secondary gains. The worried imposter knows he is exaggerating his visual symptoms but is actually worried that he may have a serious visual problem. The prevalence of NOVL has been reported to be 5% to 12% in neuro-ophthalmology clinics. NOVL more often occurs in females, but it can present in either gender. NOVL is commonly associated with concurrent diagnoses of depression, anxiety, panic attacks, and fibromyalgia, but many cases of NOVL have no associated DSM-5 diagnosis. The diagnosis of functional visual loss requires positive findings and cannot be a diagnosis of exclusion. The key to diagnosing NOVL is to first complete a full, dilated eye examination to rule out organic causes of visual loss such as refractive error, dry eye, cataract, uveitis, maculopathy, etc. Exam reveals findings that are internally inconsistent. Why does this patient have count fingers vision in one eye and no relative afferent pupil defect? 30 at the physician's repeat evaluation when encouraged to respond. Your goal is to prove and document better vision than alleged. Tunnel, rather than funnel, configuration of confrontation visual field testing or tangent screen, see image below. Probe into the history of the patient looking for a past medical history of depression and anxiety. Try to pin down the details of the onset of visual loss. Usually this information is vague, having gradually started a few days, weeks, or months ago. In adults, there may be a trivial injury that started the process. Visual acuity, VA, your goal is to document good VA in both eyes. An automated refractor can sometimes help in discovering uncorrected refractive errors. If the VA is still decreased, we like to use the bottom-up technique. Start with the 20/20 line and go up, instead of the opposite. Give lots of encouragement and tell the patient that you are going to make the print larger and easier to read, move to the 20/25 line, etc. Visual field, VF, always do confrontation VFs in these patients. Commonly, you will see constricted fields. If this occurs, move back from 1 meter to 2 meters to check for tunneling of the visual field. Remember that the normal visual field is a funnel, not a tunnel, see image below. The VF should expand as the target moves farther from the eye. An automated VF may commonly show constriction, which may be confused with glaucoma or retinitis pigmentosa. A hemianopia may also be seen respecting the vertical midline, which will need to be differentiated from a central nervous system process. Frequently, the VF has low reliability indices, which is consistent with NOVL. Also a cloverleaf pattern may be seen which is helpful in making the diagnosis of NOVL. We recommend ordering a Goldman VF if available or confrontation testing in these patients. The Goldman VF, GVF, is done by a technician with the patient. The technician is able to perform the GVF at the patient's speed and with encouragement. Motility: when a patient has repeatedly demonstrated constricted, tunnel, VF on your exam, you can lure them into offering proof of their normal peripheral VF by checking saccades. Pupil exam: The pupil exam must be performed and documented well. Pupil size, reactivity, and the presence or absence of a relative afferent pupillary defect, rapid, is paramount. It is an objective measure in the exam, unlike VA and VF, which can be subjective. Simple reassurance of a normal eye exam is an effective treatment.